appreciate the AACR allowing me to present these data at this press conference, and I'd like to also acknowledge my guests, Steve Williams from SomaLogic and Sudhir Srivastava, the head of the Early Detection Research Network. This is an important industry, university, and government study that is looking at a high-risk population of patients and was under the auspices of the Early Detection Research Network of the United States government. Essentially, it is a study in which we're looking at differences between asbestos-exposed individuals and the disease mesothelioma. Mesothelioma is that asbestos-related disease which has a 1-year survival rate across the board of 12%. If you look at the magnitude of this problem, you will see that over 28 million people were exposed to asbestos in the United States. And it's a tremendous socioeconomic problem based on the litigious aspect of this disease, not only in the United States, but in Europe and in other countries. Although there are only 3,000 mesotheliomas that are diagnosed in the United States per year, it's expected that over the next 30 years, 250,000 patients in Western Europe are going to die from mesothelioma. And over the last 14 years in the United States, from all over the world, there's been 174,000 mesotheliomas who have died. Biomarkers have been used to try to detect the disease early and are in validation, specifically soluble mesothelin-related peptide and osteopontin, but these are single markers. This collaboration between our biomarker discovery lab and SomaLogic was to look for a panel of markers using a novel technology that was designed by SomaLogic to see if we could distinguish early mesothelioma from asbestos-exposed individuals. The SomaLogic platform is based on the idea that you are using DNA, so to speak, to help you find protein. This is based on the idea that certain DNAs can be fabricated that will bind selectively and specifically with certain proteins, and then you can elute those DNAs off and then actually have the proteins left at the end of the assay. The actual measurement is of the DNA reflecting what proteins they bound. Essentially, you have 850 of these DNA modifications called somomers. The somomers have been modified so that they will not only stick to the proteins specifically, but will come off the protein in a slow rate so that there is a very good binding to the protein. The first step starts with taking 850 to 1,100 of these somomers and adding them to serum or plasma so that there is binding of these somomers with protein selectively, non-selectively, and you have free protein and somomers left. Once you have this binding performed, the somomers actually have on them a link that is photocleavable and also a biotin label so that then when you add an avidin bead to the system, the somomer will bind to that avidin bead. Then you can go ahead and biotinylate, meaning add another marker to the protein after you've washed off the unbound proteins to the bead. Once you have the bound proteins, you can then shine light on the mixture. The protein and aptamer complex comes off of the bead, and then you're left with some specific and non-specific aptamers. You then enhance the specific binding aptamers by eluting off the ones that are non-specific with dextran sulfate. Then you add another bead that is avidin-based so that you can then bind the biotin to now only the aptamer protein complexes that are left that are specific. You can then elute off the aptamers, which are DNA molecules. You have a specially designed array that is complementary to those DNA molecules. The DNA molecules already have a fluorescent label on them, and you can quantitate the fluorescence and then read that in a standard Agilent array. Our hypothesis was that this platform was going to be able to distinguish asbestos-exposed individuals from those with mesothelioma. Our archives at NYU have many mesotheliomas and lung cancers, and we used a portion of these for the discovery and validation of this process. The initial studies were to see whether we could develop a SOMAmer platform, a SOMAmer profile for this. And again, the 90 mesotheliomas that were used and the 80 asbestos exposed were divided into a training and a test set, 75% in the training and 25% in the blinded validation set. For the training, we were especially interested in making sure that pre-analytic variables that could screw up things, for example, the site where these were collected, or whether this was venous or arterial blood, was not going to influence this assay. And therefore, then, you could build a robust assay that's only dependent upon differences between the populations. It is to be noted that there's been an addition to the abstract that was sent, because in addition to this study, that was the initial training and test set, since the abstract was done, we have done another independent blinded validation of the marker profile in 38 other mesotheliomas that had not been considered for the first study, and 62 asbestos-exposed individuals, again not done in the first study, and with the addition of other asbestos individuals from another cohort from Mount Sinai in New York. This describes the data of the initial study and is a receiver operating curve which shows the training and the test set. The training set is in blue, and the area under the curve for a 13 SOMAmer panel was 0.994, giving a specificity at 100%, a sensitivity of 80%. This was then validated in the test set in a blinded fashion in which the area under the curve was close, 0.974, to that seen in the training set. What is also important is if you look at the lower table, you will see that early mesothelioma, stage 1 or stage 2, was also picked up by the SOMAmer panel. And this is the population that should be targeted for multimodality therapy, because these are the individuals with mesothelioma that will have long-term survival. What about the second blinded validation study? The same SOMAmer panel was then applied to the 38 other mesotheliomas, and again, an excellent area under the curve of 0.97 was seen, and at a specificity of 100%, a sensitivity of 40%. Again, in the second blinded validation, you could see that 80 to 85% of the early mesotheliomas could be blindly detected. Therefore, using the SomaLogic platform, which uses 850 proteins in this study, and it has been expanded to 1,100, a 13 biomarker panel is capable of distinguishing mesothelioma from high-risk populations. The classifier was trained, tested, and validated in clinically appropriate cohorts and independently blindly validated. To date, this classifier is the most accurate in distinguishing these high-risk populations from mesothelioma. Further investigation is underway to see whether there is any prognostic implications of this panel and this platform. And then finally, the SOMAmer technology is being used for biomarker discovery in other malignancies through the Early Detection Research Network collaborations. Thank you very much.